Hi everybody, I am Dr. Rahi Victory. Welcome back to Fertility Fact or Fiction for the new year. So this is our first show of 2021. Happy New Year to everybody. I hope that you had a safe and enjoyable holiday. I feel terrible for all of the youth out there and the adults who were hoping for some relief from this pandemic and an opportunity for a good time. But unfortunately, that was not in the cards for us. So we are hopeful that you enjoyed yourselves nevertheless, had time to be around people that you love and care about, and enjoyed some quieter time than we traditionally have in the past. And we're safe. God willing, everybody is still doing well. You have not contracted this terrible virus, and things are going okay. So we are trying out some new technology tonight with a new software package. So we're working out some of the kinks. We started a few minutes earlier, and now we're back up and running again. And hopefully we'll be able to see all of your comments on the one screen that we're using. And I no longer have a laptop in front of me, which I traditionally do. So this should be an interesting experience for us. Want to just quickly address the fact that in Ontario and in Canada, the OBGYNs have been somewhat up in arms about the fact that so far the government is holding back on providing the vaccines to pregnant and or breastfeeding women. So people have been asking us this question about whether or not it's safe in pregnancy, and the answer is we only have surrogate markers right now of whether or not it's safe in pregnancy. So what are those markers? The markers are that, number one, we know that women that have contracted COVID while pregnant have not experienced a higher risk of miscarriage. So this has been looked at. Admittedly, the numbers are small, but no one has demonstrated a higher risk of miscarriage. There is some suggestion of preterm labor, maybe that the babies are a bit smaller, but certainly no risk of miscarriage. So in terms of complications, they do not seem to be overwhelming. There are maternal risks, pneumonia, ICU admission, hospital admission, problems with breathing, the typical problems everybody is having with COVID. But there are no fetal risks that appear to be significant from the infection while you are pregnant. And the vaccine would, in theory, induce the same immunological response and as such would cause the same sort of problem. So we are not seeing that at all with the actual infection, and therefore the vaccine shouldn't cause it. The other element that has been looked at is that approximately 30 patients who took the Pfizer vaccine either became pregnant or were pregnant but not detected when they first got vaccinated or took their second shot. And all of those were followed for the duration of that trial, and none of them demonstrated any significant adverse effects from having been vaccinated. So again, very, very small numbers. Is it possible there is something that will turn up later on? None of us know, but certainly based on the information that we have and the numbers that we have, there does not appear to be any reason why pregnant patients and or breastfeeding patients cannot take this vaccine. Certainly breastfeeding is almost certainly safe. And from the standpoint of pregnant patients, it's most likely safe because we're not seeing any harm from the actual viral infection. Now, I had a, shall we say, lively debate with a Instagram individual who was clearly anti-vax, who believed that she knew all the answers to the vaccination questions and had already done all her own research and knew everything about the trial. Unfortunately, that individual and many individuals are simply promoting false narratives and information about the trials in an attempt to either scare people or drive you away from the vaccination. None of those claims are true. So these trials were randomized, double-blinded trials for both vaccines, the Moderna and the Pfizer vaccine. Yes, I'm sure people at Moderna and Pfizer made millions of dollars from working there both before these trials and maybe even during or after these trials. And quite frankly, why wouldn't they? They are hardworking individuals like any of you and myself, and if they're entitled to stock options and it's an opportunity to take those stock options, they're going to. Having said that, it had absolutely nothing to do with the data that was analyzed, because the Moderna trial in particular had its publication released by the Data Safety Monitoring Board, and they had nothing to do with Moderna. They were members of the study group, none of whom worked for Moderna. So all of these claims that it's all about money are not coming from science. They're coming from a desire to kind of sabotage this whole vaccination. Why you would want to sabotage this, I don't understand. The other claim this individual made was that it only saved 30 people from getting severe COVID virus, which was just like egregiously ignorant. So the reality is 14,000 people were spared from getting COVID permanently, and 14,000 people remain susceptible. Yes, in the 4 months of the Moderna trial, about 200 or just less than 200 people actually contracted COVID in the actual placebo arm, but those people were just 200 of the 14,000 in that time frame. As time goes on, A, those people spread it to other people for sure. We know that this virus spreads, and very quickly. And B, the other 14,000 people that didn't get the actual vaccine, they got the placebo, are still at risk for getting COVID. So there is a time element built into this, which is critical for people to understand. So the vaccine does appear to be safe. Certainly for non-pregnant, non-breastfeeding people, it is. For the patients who are breastfeeding and or pregnant, it is probably safe. We have no evidence to indicate that it is not. And certainly if you're in a high-risk category, you're a frontline worker or you're exposed to patients who have COVID or you're in long-term care, you definitely should consider getting vaccinated. And I believe as well, along with the rest of the society in Ontario and Canada, that it makes a lot of sense for those patients to be included. And to the best of my knowledge, they are considering running the trials on pregnant and breastfeeding patients very soon, because we were actually invited to participate in that, but we have not heard back yet whether or not we've been selected as a site. So I think that there is real potential for that to occur, and we are excited about that potential. I do agree that everything merits investigation and study, but the reality with all of this is that we need to see what the data shows. And until then, we need to make our best guess, or a most educated guess that's possible. And that educated guess is that it does appear to be safe. So with that, I hope that that makes sense for everybody. We have a little post on that already on Instagram and YouTube, and hopefully you guys can follow that. Make sure you like, comment, and subscribe. That's always important for us to help us grow and help us do better. So tonight's topic is one that I found quite interesting, because we wanted to see if a previous history of a poor response during a stimulation cycle or an IVF cycle actually predicts your chances of having a poor response in a subsequent cycle. So obviously, a lot of people don't stop at just one try. If they fail the first time, either because they're insured or they can afford it, or they just have that desire to continue trying and the ability to do so, they will try multiple times. And so the question was, what if you don't do very well in your first cycle? Does that predict how you will do in a subsequent cycle? And the answer to that question came from a new study, which actually is as yet unpublished. It's still in proof, but we get access to that with the access I have through the library system. And I wanted to share that with you. So it's a study coming from Bourne Hall, which is actually the original IVF facility in the world. The first place IVF was done in the UK. And they actually analyzed 1,224 patients to see if their previous history of a poor response was going to be predictive of their subsequent response. So in other words, if you didn't do great the first time, what was the chance that you were not going to do well the second time? And then they went back and analyzed it to see if there were specific factors which were significant in terms of determining whether or not you would have a predictive value in the next time of doing poorly or doing okay. So they took 1,224 patients, they studied them over a couple of years duration, and they collected as much data as they could on these patients. So this is actually a fairly brief talk with you guys tonight about this, because the first and quickest part of this is that I'm sure you all want to know, what were the criteria for a poor response? Super easy. They said just less than 3 follicles or 3 eggs retrieved, and it was less than or equal to 3 eggs retrieved. then they said, okay, that was the definition of a poor response. So if you had 3 or less eggs, they said you didn't do well enough. That's considered a poor response. And then the second part of it was, did they have any exclusions? And they did, but their exclusions were all very reasonable things that they looked at. And certainly when the study comes out, I can refer you to those, but they were, for all intents and purposes, very appropriate things that they considered for cases that they would exclude. So the next part of it was essentially what percentage of patients did poorly a second time around if they did poorly the first time. So you made 3 or less eggs the first time. What was the actual percentage of patients that did poorly the second time around? And the answer to that is, out of that 1,224, only 141 or 11.5% did poorly again the second time around. Now keep in mind, some of those patients only made 4 eggs the next time around, but some went on to make actually more than 15. So it's a very interesting study in that there are times where you can do quite poorly the first time and then do well afterwards. And actually it looks like 88.5% of the time, an overwhelming number, you are likely going to do better the second time around than you will the first time. So this is very, very valuable information. So then they went into it in detail and said, okay, let's kind of look at a sort of assessment of what factors were important. So number one, they looked at age. So if you were less than 35, only 33% of the patients had a poor ovarian response in a repeat cycle, whereas 56% of patients were less than 35 who did fine in the subsequent cycle. So if you had poor ovarian response the first time and you're less than 35, there's only a 33% chance in that age group that you were going to have a repeat poor cycle. For the patients that were 36 to 37, it was 31.2%. And for those that were 38 and older, it was a little bit higher. It's up now to 35.5%. So about a third of the group that had a poor response was in each of those age groups, but it's also important for you to know kind of where that breakdown is. Body mass index was actually not a factor, so it didn't matter how high or low your body mass index was. It did not contribute to your prediction for doing well or poorly the second time around. And that's really important because we've talked about the predictive value of body mass index on your cycle outcomes, on your frozen embryo transfer outcomes. It is definitely important on doing any kind of fertility work. But in this particular case, if you did poorly the first time, regardless of whether your weight was high or low or normal, it had no impact on whether you were going to do well or not the second time around. They looked at the cause of infertility, whether it was male factor or female factor. Again, that showed no significant difference. The big one was whether your AMH levels were low or high. So if you had an AMH level that they considered low, which was less than 5.4 picomoles per liter, and that's in the decimal range for those of you that use nanograms per mil, then 41.8% of the patients with poor ovarian reserve had it again with, poor ovarian response, had the same thing happen again in the repeat cycle. So if your AMH is low, it is highly predictive of the fact that you will do poorly again. And that's compared to just 7.8% with that same AMH who did better in the second cycle the next time around. If your AMH was average, which they classified as 5.4 to 25, 49.6% had a repeat cycle that was poor versus 55.5% in the non-group. And then if your AMH was high, only 8.5% were in that group that had poor ovarian response in the second time around. So again, it looks like your AMH is highly predictive, and this had previously been shown as well, and that makes a lot of sense. In fact, arguably, if your center knows that you have a high AMH and they're moving forward with your cycle looking like you're only going to get 2 or 3 eggs, that's actually one where we would typically stop the patient and say, listen, you're not doing as well as we would predict you to do. As long as your meds are covered, we should be stopping this, restarting again, figuring out what went wrong, and then beginning the process, because it is truly unfair to you to have to go through all the shots, all the cost potentially, all the meds costs as well, and then the egg retrieval, which certainly is never 100% comfortable during or after, or even before, and then have to endure that to get 3 eggs when we know you could potentially be getting 15 or 20. So clearly that's a really important thing for us to know about. And if you have a high AMH and you are not doing well, this study is actually telling you that you should probably abandon ship, so to speak, because the next cycle around should do much, much better. The number of eggs retrieved was also highly significant. So if you had less than 3 eggs retrieved, that represented the majority of the group in the poor ovarian response in the second cycle. 4 to 9 had a medium kind of number, and if you had 10 to 15 or over 15 eggs, then clearly you were going to do much better the second time around. So those patients, who had a reasonable response initially were going to have a reasonable response later on. Now, the quizzical thing with that is they actually said their inclusion criteria was less than 3 eggs, so I'm not sure where these patients with 10 to 15 came from. They don't really delve into that in this study. The patients who actually had an embryo transfer from their first cycle had a reasonable chance of having a poor ovarian response still, even if they had a embryo transfer from the first attempt. So getting an embryo transfer does not necessarily predict whether or not you will do well in a subsequent cycle. They also looked at things like embryo freezing, again, highly significant. So if you had embryos to freeze, you probably had less likelihood of having poor ovarian response the second time around. And then the interesting thing that was very fascinating for me was actually they looked at how long it was from your first cycle to your next cycle. And they compared less than 1 year and greater than 1 year. And again, there was actually no statistically significant difference. So obviously a lot of patients who do poorly get panicked. They think they got to go again and again and again. And we've shown you a study before which showed that even up to a 6-month delay made no difference. This study is actually saying that potentially even up to a year is not making a difference. So very valuable, important data. The other thing that's critical is that even in that group that had a poor ovarian response the second time around, the ongoing pregnancy rate per cycle was 21.3. And in the group that actually didn't have a repeat of the poor ovarian response, it was 37%. So that is a very, very important number, because this says that even if you don't do well with one or the other cycle, you can still ultimately get a reasonable pregnancy rate, maybe not high, but a reasonable pregnancy rate, which gives a lot of hope to those who are struggling and really trying hard but not getting the robust numbers that they want. So I always say it's not all about the numbers. Numbers are important and you have to understand your numbers going into it. But keep in mind, statistics are just statistics. So you have a 1 in blank chance of an event occurring. It doesn't mean you won't be that one. So somebody is going to be that one, and maybe it will be you. You just have to feel comfortable with that chance. So if I told you you had a 10% chance of winning the lottery and it's going to cost you $10 to get that 10% chance, you might feel comfortable with that. Versus someone that is told that they have a 1% chance of winning the lottery and it's going to cost them $1,000, maybe now they're not as comfortable. So as long as you know the numbers and you can make a decision for yourself, that's perfectly fine. So the authors then went on to create an actual graph where they looked at the predictive value. So in terms of what's the fold of risk or chance that this will make a difference for you. So if your AMH was low, you had a 3.54 increased risk of a poor ovarian response the next time. So in other words, a 250% increase in your risk that you're going to have a poor response second time around if your AMH was low. And conversely, if your AMH was high, you had a 64% reduction in the chances of having a repeat poor response. So again, that AMH value looks very, very important. In terms of the number of eggs, if you had less than or equal to 3 eggs in that first retrieval, then you are going to have a 14-fold increased risk of having less than or equal to 3 in the second. If you had 4 to 9, it was still a 4-fold increased risk. And if you had that higher number where you're over 15, it was drastically decreased, almost by about 70%. And then they did relook at the time between treatments, and they did on secondary analyses when they plugged it into this equation accounting for all the factors, find that there was a little bit of a difference when you're waiting more than a year. So if you're repeating your cycle within a year, they used that as the reference. And when they compared to that in this secondary analysis where they controlled for all of the risk factors, they actually said that maybe there is an increase in risk of failure, and it's almost double. So waiting too long may have an impact, but certainly within a year, it is not a problem. If you're waiting more than a year, it may lead to some complications. So they actually developed this predictive sort of graph, and that predictive graph is really important because it actually calculates something called the area under the curve, which is a sensitivity versus a specificity plot. I won't bore you with the statistics, but the closer it is to the number 1, the more accurate this model is at predicting your outcome. So anything at 0.5 is a straight line across the graph, and what you want is like a complete inverted L shape where it's very sensitive and very specific. So what they got for this graph is a curve, which is typically what we get, but it's 0.83, which is actually exceptionally good. So this is a very predictive model, and they then took that model and they applied it to real-world group prospectively, and it still held pretty well. Not quite as strong, but still over 0.7. I believe it was 0.73. So that's still a pretty strong model in terms of predicting your outcome. So is it true that a previous ovarian response can predict a poor response, can predict a repeat poor response? The answer is some of the elements of your history can help you predict it, but it's actually mostly false because only 11.5% of you will actually go on to have a repeat cycle where you're not producing very many eggs. So there is a lot of hope moving forward that if you do repeat cycles, there is a chance that you can hit that golden egg and end up with the desire of having a baby fulfilled. And so that's really, really hopeful, important information. So thanks for joining us for the Fertility Factor Fiction Show. Make sure you like, comment, and subscribe. It's critical for us to help grow this for you so that we can reach as many people as possible and bring this valuable information to them.